Welcome everyone to this P3 showcase on how SickKids nurses digitize their incident command center. We're thrilled to be your host this afternoon, and we will be hearing from two amazing nurses from the Hospital for Sick Children on how they enabled and empowered their teams to do more and achieve more with technology. This session will be presented by the SickKids group, and if we have time for questions, we will address those at the end of the presentation. We encourage everyone to connect with the speakers via the virtual event platform. Good afternoon, everyone. My name is Shubha Ananda, and I'm the technology lead from Microsoft, supporting healthcare organizations on their digital transformation journey. On the virtual stage today with me is my co-host and my partner in crime, Ali. Ali, can you come off mute and introduce yourself to the team?
Thanks, Shubha. Hi, everybody. My name is Ali Sharifi, and I'm a solution specialist in the cross-solution and industry team in Canada. I work with healthcare organizations across the country, and I'm really excited to be part of this conversation to showcase great innovation delivered by SickKids team. Back to you, Shubha.
Thanks, Ali. So let's quickly get on with our conversation for today. Without any further ado, ladies and gentlemen, let me call on this virtual stage our presenters, Andrea and Katherine, to introduce themselves and their role at SickKids. Andrea, why don't we start with you?
Great, thanks so much for that. So hi everyone, my name is Andrea McCormick. I'm the Senior Manager of Quality Management and Emergency Preparedness here at SickKids. My background is, as mentioned, I am an RN. My clinical background, I worked in the ICU for about 8 years before I got into administrative leadership roles, which included doing quality improvement in the ICU. I was also the manager of the ICU for a year, and now I've been in this current role in central quality at the hospital for about 4 years. And Katherine, go ahead.
Sure. Hi, I'm Katherine Cheung. I'm a quality improvement specialist for SickKids. I'm also an emergency nurse by background, and my other hat in the hospital is clinical practice lead for the outpatient program. And I've been a nurse for 7 years and have been in a main role for about 2 years now.
Welcome and thank you, Andrea and Katherine, for taking time off your busy schedules to share your story with us. We truly appreciate it. Andrea, maybe let's start with taking the audience a few years back to your days of the physical incident command center. What was the experience like for the nurses? Can you share what that looked like? And maybe also talk about some of the pain points you experienced?
Sure, I'd be happy to. So SickKids, like most healthcare organizations in Ontario, adheres to the incident management system as a way of organizing ourselves during crises that affect the entire organization. So during that time frame, what we would be managing is using very common language, titles, and using this concept of command and control, which actually originates not only from the military, but also from early firefighting and EMS strategy in the 70s and 80s, responding to disasters. So yes, we use this IMS structure, and the command center is a part of that. The command center is made up of various different roles. It's a small group of leaders that are on call for different major portfolios of the hospital: clinical facilities, protection services, which is our security, human resources, etc., made up of a number of probably 9 or 10 roles only, where we would be actually receiving information about these types of critical events, what they might be, and I'll give some examples of that, and then making decisions about what our plan is to execute on an organizational level, our plan to communicate, and our plan to actually start dealing with whatever that issue may or may not be, or to clear that issue. In terms of where we've come from, traditionally our command center was, and we still do, host a physical command center on site. And the way that we managed that, in particular pre to COVID, was during these major color codes that would be announced that affected hospital operations, we would all convene physically in one room. And have paper copies of things that we needed to complete. And most of our communication strategy with the outside of that room was telephone based, but also as the years went on, through the mid-aughts and into the current state in 2019, a lot of informal ways that we were getting information because we weren't getting standard flow of information to the command center. A lot of sidebar texting, a lot of sidebar conversations and phone calls that weren't a standard kind of way of getting information or predictable. And then, of course, what we did see in the command center during COVID was this great opportunity, the fact that we all had to become very savvy with online portals and online tools such as Microsoft Teams, such as Zoom, as we're on now. And that was actually a huge benefit to us to actually get over the precipice of using a tool like that for a virtual command center, which was thought to be too onerous for training, too onerous to accomplish prior to this. But we also recognized in terms of pain points with the command center, even before we had a physical command center, a virtual command center, there was a need for us to have a virtual standing in a command center. And that would be in relation to events where we actually do not want people circulating in the hospital or traveling to another place in the hospital. So an example would be a code green where there's an evacuation. It's likely that you wouldn't be able to get to the physical command center to host that. And then also other type of threat events that, as we all know, in the current environment that we all live in these days, things like an active attacker or shooter, bomb threats, etc. Those are not options where we would want people to be housed in a singular area. We would want them to shelter in place, but still be able to connect and make decisions rapidly for the organization. So some of those are the major pain points. I would sort of say what we found in a lot of simulations that we did do with our physical command center prior to COVID was, I called it the proverbial black box. We were not getting good information in. And so we were constantly out of date of what was actually happening on the ground. And then conversely, we could not get really good information out in the way that we wanted to.
Yeah. Absolutely. That's a nice way to put it, right? A black box. I can definitely see the pain points that you mentioned there. Katherine, if you can kind of shed some light on what has changed since. How has the process evolved today with the digital command center? And what, if any, has been the user feedback? How have users accepted your solution?
So I wanted to say that our command center is fully virtual. We do have physical Teams capability within the room if we do want to meet in the command center. But actually, most of our calls that we responded to this year has been mostly virtual and during off-business hour, and we were able to gather our on-call team relatively quickly. So the command center is actually just hosted within a Teams channel. Initially, when we first started, it was very basic in terms of user functionality. It was just a channel, and then we all start a meeting within that channel. And that's how we create a conversation and how we respond to color code. Since then, we really looked at how we can leverage Microsoft platform as a whole and bring in new tools that will allow us to create a efficient workflow. So some of the stuff that we have completed in the last year, including going live with a code yellow and search back reporting tool, which is basically a missing patient or a suspicious bomb packages. So in those situations, the area lead will have to search the hospital and the area and report back to make sure there's no suspicious package or patient. And previously it was all telephone based. And now we have digitalized it into a form, and then we can pull that information into a real-time dashboard to see which area has been searched and which area has not been searched. We also created a chatbot using Power Virtual Agent to help the on-call team to activate the command center, find a specific job during a color code response, and also hosting regular orientation and training for the on-call team. The feedback so far has been very positive. Previously, there was a comment about driving half an hour to the hospital to be able to create an efficient response, and now they're able to hop on to the command center during off hours while they are maybe walking. They're not usually like in the hospital. A lot of the color codes occur after like right at the end of business hour or overnight. So they were able to basically respond still efficiently, even though they're not physically located within the hospital. And it really allows the frontline staff to create a much more seamless experience in reporting and sending information to the command center and be able to automate information that will enable decision making. There's a lot of information folding during the color code. People tend to be very nervous. They ask a lot of questions. So really having that information polling in real time and be able to control what type of information is coming in gave us a lot more flexibility on how we respond. And we also is able to kind of give the frontline staff the information they needed to do their job during those color codes.
That's perfect. Thanks for explaining that, Katherine. Wondering if there is a demo or any sort of videos that you want to show at this point to kind of paint the picture for audience here.
We can show you our code yellow and back search reporting tool and what that looks like. So we'll show you the interface on how a area lead will report a search request, basically searching for a missing patient or a suspicious package. Oops, we're gonna go back a slide. So as you can see, that was the reporting interface. Once a user reported their search result, it's integrated into a Power BI dashboard, which is visualized on the hospital floor plan. So you can see it's color coded based on which area has been searched and which area has not. And you can drill it down by search times, whether or not it's located in the inpatient area, outpatient area, or the commercial area. And that's really helpful for repeating searches. So sometimes the patient is still physically in the building, but we haven't been able to locate the patient yet. So that might result in a repeat search. So allowing the users to be able to submit multiple entry and still be able to filter those results was really helpful. It's actually also fully embedded within the Teams channel so that the command center can look at this as they're having a conversation about how to respond to the code yellow or code back. And the app itself also have the search instructions embedded, just in case the user just need a just-in-time refresher on how to search a room and navigating all those equipment, how to locate and identify suspicious package, what to do if they do locate anything suspicious, and how to report a security concern. So we kind of created a custom in-house solution based on what our needs within the hospital is, what we have seen based on previous events, and also feedback from our nursing users. We did quite a bit of testing to make sure the form is actually makes sense to them, that they're able to quickly do this. And like we mentioned, the previous driver was that the telephone based workflow tends to call up the line, and that resulted in multiple phone call. People weren't able to actually call in to report the search result. So we do monitor performance of the application and see how long it takes for a user to fill out a search result and how long it takes to connect within the application. So within PowerApps, there is a performance analysis that we utilize and monitor. So the time to reporting screen is 3 seconds, and usually most users is able to complete the search result within a minute and be able to submit it. And this is part of our ongoing monitoring in terms of performance and how well our application is doing compared to our previous workflow.
And I can just I can add on to what Katherine is able to give that background. We have the benefit of having actual code yellow and code black events in the past 2 years to inform a lot of these failure modes that drove us to kind of work towards looking at a solution like this to really enhance that process. When Katherine says, you know, calling the physical command center was getting blocked, as you know, healthcare staff, particularly nurses, are persistent. So they were trying to find someone who would receive their call and say that, yes, we're all clear, because they wanted to ensure safety of patients and family visitors. But it meant that our locating department was flooded with calls. Our protection services department was flooded with calls, and we couldn't get through if there was anything aberrant found. So all of those good intentions with poor design design lead us to having a worse outcome or a prolonged length of a code. So I think, and I can say, Katherine developed these for us. We did the Teams page together, but certainly the actual app itself, Katherine was instrumental in actually developing and changing and collaborating with our IT team, but certainly was the lead in actually developing.
Thank you so much, Katherine. And this is really impressive and exciting as we look at these solutions that you built. A question for you, Andrea. In terms of roadmap, we're trying to understand where do you want this solution to be next year, or where do you envision as the next steps for the solution as a roadmap?
So I think what we looked at when we did a program evaluation in March of 2021 was some major pillars of basically a SWOT analysis of our strengths, weaknesses, opportunities, and threats. And under opportunity was advancing and augmenting our technology for emergency preparedness. And it deeply embeds with a lot of the strategy that we're moving forward with, which also includes really rigorous and staff-informed update of a lot of our major color code policies. We're currently doing that right now with Code Black as a result of a Code Black that we had in the summer. And we're doing a number of tabletop with frontline staff, not only to use and test the tool and give feedback on it, but also to give us feedback on the instructions and the notifications that we are putting forward during these events. So our plan is that we would be going through our policies on a risk-based model to update them using that same model, and then test these things at a hospital level throughout the year as things progress. So we do plan on doing a Code Black exercise at the end of the month of June, so that we can test these functionalities and test all of the new different tools that we've developed, not only technology, but resource-based. When we think about moving towards like where we want the program moving towards, we think about that SWOT analysis, and in particular, really seeing where we are right now, which is kind of year 2 of a 4-year, maybe even a 5-year plan, which is not only really wanting to have good solutions baked in for staff, but making sure it's helpful and moves us forward in our mission, which is to get good information in, good information out, and controlling the message and controlling the narrative early in these color codes for the hospital. One of the things we hear, and we mentioned it with the telephone access, but we really want to focus on removing barriers to information. So while it is great to have paper-based emergency preparedness binders, which we do have in most of our supposed to, all of our clinical areas, as you all know, those quickly become out of date. And there are a lot of instances where we want somebody to have access to something where the binder might not be within reach. A great example of that would be if you were to receive a bomb threat via phone. It would be great if the staff could find the checklist that they need to run through with that caller within 1 or 2 clicks. And be able to get information rapidly, whether that be on their phone or whether that be on their desktop computer if they were close to one at the time. We are blessed at SickKids from the fact that we have integrated with technology in our clinical areas very well, from the fact that we use cell phones for our clinical alarms on the inpatient wards. So the nurses have a SickKids cell phone that they carry that has all of the alarms for their patients for the day. And so we can actually push and embed a lot of our materials, whether it be some kind of actual app that could be pushed for emergency preparedness with a lot of these types of material, whether it be reporting or whether it be accessing resources would be really key for us as well.
Thanks, Andrea. That's really really important insight for everybody here. Now, question for both of you, maybe starting with Andrea first. What learning can you share with other organizations going through the same journey? And how do you think that any other organization can leverage this approach that you've taken? Again, talking about building an application as well as overall innovations that you're driving within the SickKids.
Yeah, I mean, I think it was a good opportunity during COVID crisis to leverage that knowledge and skill base that people had to rapidly build, but also people's willingness to try something new in the moment, because a lot of the time we didn't have much choice, and that we actually did leverage that to our benefit to be able to to put out new tools and to actually give it a try and have people use it. So I would say that was hugely in our benefit at that time. We also were very lucky to have somebody on our team who could help us prioritize builds, because obviously our IT team is very, very busy with different requests from all over the building. So this was great for us to be able to say, hey, this is what we can do with this product, and this is what we have done so far, to really showcase the usability and how people can actually have that embedded into their day-to-day. But I would also say for any organization, the other part of my job is quality improvement. And we've brought that with us as we move along for our emergency preparedness program. So we're using those guiding principles of PDSA's rapid improvement cycles and having really good data and stakeholder involvement to really guide our use. So we're not rolling out a tool, we're rolling out a tool that's been tested with X amount of frontline staff and had input and had major iterations. Same with our new code black policy. And as I mentioned before, having that stakeholder engagement is going to be key. But I have to say as well, I have a leadership team here at SickKids that is very happy with us to try and pursue new things within this department and within our team. So we really have got a lot of support from our senior leadership, which has been really great for us to actually move things forward.
And I guess I'll just add as like a Power Platform user. For me to kind of learn Power App before being exposed to the Power Platform, I don't have any computer science background. So I was able to kind of pretty quickly learn Power App within the year, and then expanded to Power BI and Power Virtual Agent. And I want to say, like, just as an end user, be able to achieve your vision, because be able to integrate multiple components of the Power Platform is really what makes some of the solution really successful. And being able to do that as an end user working with the IT team was a huge win within our organization. And I think having that ongoing partnership, and like Andrea mentioned, a lot of usability testing and human factors, we want to make sure people are filling in the right information and that they feel comfortable using the tool. So we kept that in mind while we designed some of these solutions.
That is really important in terms of having the end user's perspective in mind. We have this terminology called design thinking. Essentially, we sit with all these frontline workers and business users, understand their challenges, and translate those to user journeys and workflows can be automated. So that's really impressive. And this is really an excellent example of how any organization, an IT leader within those organizations, can digitally transform their businesses by enabling business users and frontline workers, which we typically call them citizen developers, and can enable them with these low-code technologies such as Power Platform and Microsoft Teams to be able to transform and innovate across the organization. I know that there are probably a few questions within the chat, but thank you so much, Andrea and Katherine, for a very interesting presentation. And thank you to attendees for joining us in this P3 showcase session today. To learn how we can extend this solution, how can you might have you might have scenarios within your organizations that's similar to this. You can reach out actually to emergency.preparedness@sickkids.ca. I will attach this email actually within our team, within our Zoom chat. And with that, have a great rest of your day. Thank you so much, everybody.
I'm just typing some answers in some of the in the chat here as I see them here. I think Katherine is too.
Absolutely. I think we have some time left here, but yeah, definitely we can either type them down or respond to them since some folks are still on the call.
You know what? Maybe I'll just respond to some of them rather than type. I see what's what has been the greatest challenge with implementing the command center virtually? There was initial trepidation, especially with some of our more senior team members, in actually being able to feel comfortable accessing or not thinking, oh, I'm going to press something wrong and that's going to do something. And we're like, no, it's just going to start a meeting. Because I think people think about it being like our emergency notification system, like, oh, if I press this, it's going to go out to the whole hospital. Nope, it's not. It's just the people on the Teams chat. So just kind of going through that, we did a lot of FAQ work. We did a lot of simulation. And then we, at one point, we had a weekly touch base with, because every on-call team is ad hoc. Right, so you have new people on call from each team that are representing each department every week. So for a while we had a Monday morning meeting where I would just say, just a reminder, this is how you access it. This is where you find your different materials that you need, and answer any questions in the moment. And we've been able to kind of transcend that and not have to do that every Monday now. And I know, Katherine, you responded around chatbot.
Yeah, I guess just to add to the chatbot, it's basically when we had those challenges in terms of activating the chat, it basically guides your user through an automated workflow. So it will start a Teams meeting on your behalf and notify who is on call. And basically we leverage how it integrated with Power Automate. That's basically how we kind of guide the user through a standardized workflow, because we don't want an imbalance in terms of technical confidence for between the on-call team in how they respond and how long it takes for them to activate a command center. So we want to standardize some of those responses as well.
And I just see as well, any challenges with change management? Always. So any project, any change that I've introduced during my time in quality improvement at SickKids will always come up against some issues with change management. That being said, I feel like this was a highly motivated group of people who do an on-call role that were feeling insecure anyway about the current state. So it wasn't a tough sell to be able to say, oh, I can, now I'll be able to connect with somebody who knows the ins and outs of emergency preparedness much quicker than I could before. In some ways, it was really seen as actually enhancing and relieving a lot of stress for people. So it was really just overcoming the technological perceived challenges with it. But the feedback overwhelmingly has been very, very positive from that on-call team, which represents upwards of around 150 different people who might be in those different roles on any given on-call schedule. So it has been very good from that perspective. And I would say, like I said, I had less issue with trying to push it from the technological point of view, because we didn't really have much choice during COVID.
Yeah, one other item that I think would be good to also highlight based on my interaction with Katherine and your team, Andrea, is that kind of selecting a smaller group of people to be able to pilot things with them. We have this concept of crawl, walk, run, and maybe on the crawl stage, we start small and we, fail fast. We make it successful faster. So having that a smaller group of stakeholders or end users who are interested to try new things, I think will drive a lot of impact and innovation within the organization.
Yeah, absolutely.
I see there's one more question in the chat window there, asking if all the staff is enabled with mobile devices.
So no, for the most part, only the bedside nurses in the inpatient areas. So that wouldn't include our ambulatory clinics or our ICUs have those types of SickKids phones that are specifically for alarm management with their patients. That's a very specific type of program for that, but we can take advantage of it for our purposes for emergency preparedness. Otherwise, in terms of having a mobile device that's SickKids issued, it's the usual process hospitals would have. Most managers have one that's been issued, and senior leadership, but the average staff, their interface with it would be more around that type of phone alarm system.
Yeah. New question from Kevin on how long this solution has been in place and if there are other examples that have also been implemented at SickKids.
Yeah, so from a process improvement point of view, we do use that lens. Our team from Quality Management centrally does use that lens, and with our improvement strategies. This has been in place since, I believe, oh gosh, I believe it was the fall of 2020. It wasn't immediate in the beginning of COVID, as our attentions were focused elsewhere, like actually having enough PPE, actually having enough supplies and things like that. We all kind of, our job titles change very rapidly to accommodate those crucial issues in the moment. I would say we were piloting in the fall of 2020 and we went live in 2021 January, I believe, with the command center. The tool itself, the search tool, went live in April of this year. And then we anticipate we will get a real-time test of it when a code yellow or code black does occur. But until then, we will be testing it then with our hospital-wide in a more formal way with our actual simulation planned for the end of June.
And in the other examples of organization, PowerApp is actually quite commonly used for a lot of the process improvement work we do around the hospital. We use it for vaccination reporting, absenteeism reporting. So it's actually quite, the staff are very familiar with using the Power Platform to report something or to fill out a form. So it's actually, they are very comfortable using the application itself, and most of them have heard of PowerApps, basically.
Okay, I think that's it for the question. And it is definitely very, very impressive. I think that is something we are all in agreement with, that it is definitely great to see nurses, great to see individuals taking technology in their own hands and helping resolve issues and problems and making improvements, not just for their team, their department, their floor, but for the entire organization, and really empowering everyone, as I stated at the start of this presentation. So Andrea, Katherine, thank you so much for all that you're doing. And we can't wait to hear more of the things that are going to come out from your team specifically, and SickKids more broadly in the next few years to come. So thank you so much.